All right. So once again, I'm Dr. Samuels. Everybody can see the slide? All right, good. So, right, if you have a question to ask, there's an icon, it's blank. What's blank? Okay. Is it everyone seeing a blank slide or people can see a proper slide? All right, so it looks like it's just that one person. You may have to adjust your settings or log in and log back out, log out and log back in, so you can see it properly. All right, so there's an icon at the bottom of your screen, bottom right hand corner with a raise your hand sign. If you have a question, just press that icon to raise your hand. And if you're going to ask the question, ask it with the mic and don't write the answer. Don't write the question because I have to come out of my screen to see the chat and it becomes very disorienting when you have to keep doing that. So if you have to raise your hand and you have to ask a question, ask it through the mic. All right, so let's get started. So primary malignant bone tumors, fortunately, there are not a lot of tumors in bones, and it's not very common to have tumors arising primarily from bone. As I said, very rare. When you have less than 1% of all malignancies, more common in children than in adults, but in spite of this, it's still only 5% representation of all the malignancies in children. Usually as you get older, you have less and less chance of having a primary bone tumor. And what you find is that patients who are above 70 years of age almost never have a primary bone tumor. And if they do have any kind of bony lesion, it's most likely to be due to metastatic bone disease, which we talk a bit more about later. Now, as I said, there's just a handful of primary bone tumors. And the four main ones you see on the screen there are the ones that we're going to be discussing today. The rest are not so common, much less common. So, you know, it's not really much to really discuss specifically for the remaining ones. So the four main ones, multiple myeloma, osteosarcoma, chondrosarcoma, and the ever popular Ewing sarcoma. So let's start with the osteosarcoma. Commonly thought to be the most common primary malignant tumor of bone, but it's actually not. The most common primary malignant tumor of bone is multiple myeloma, but we'll get on to that later. So osteosarcomas, they're malignant, and what you have is that you have this bone-forming tumor, which comes from the mesenchymal stem cells, which are the osteoblasts, and these osteoblasts are usually located in the periosteum. It usually also forms what they call osteoid as well. So usually you have this bone-forming tumor from the osteoblasts, and it's mixed in this osteoid, and that's what is the main histological representation of osteosarcoma. Now, you can have osteosarcomas, which can, for want of a better expression, they're primary, meaning that they arise in normal bone, right? So bone which is non-pathological prior, right, now develops an osteosarcoma, and they give it the term primary osteosarcoma. It's a bit of a clumsy expression, but that's what it is. And usually how people get these is generally unknown. There are a lot of theories and a lot of multifactorial influences which may bring about the formation of these osteosarcomas from normal bone, but we're not quite sure as to the precise basis of origin. Now, people who get them are usually of the adolescent age group, so usually between age 10 and 20. A lot of preteens and teenagers those are the people who you tend to see a lot with these osteosarcomas. Now, if you have osteosarcoma arising bone which was already pathological, such as bone which has like Paget's disease, bone which has been irradiated, or if you have a lot of infarctions arising in the bone, it can actually lead to a secondary osteosarcoma. So that's what we mean by primary versus secondary. One arises in normal bone, the other one arises in bone which was already diseased. Now, how do these osteosarcomas present? These kids usually complain of pain, which they have not usually have an insight in trauma, but they may have had some kind of insight in trauma, or they may think that they had some trauma, but the trauma doesn't seem like it would have been enough to cause the persistent pain that they have. And instead of the pain getting better, it tends to progress. It's worse at nights, and they find that when they do particular activities involving the limb involved, then it precipitates the pain. And as time goes on, any activity involving that limb just starts to get more and more difficult. They may have swelling to the limb, right? And as I said, there may be a history of trauma to the bone, but oftentimes this doesn't really represent what is actually going on or actually contributed to anything that's happening. And it may develop a mass, and usually this mass is tender when you palpate it. If you look at it, you may see it looks red and erythematous, and it grows in the ends of the limbs. As the tumor grows and it starts to involve the area closer to the joint, you find that you may have a decreased range of motion in that particular joint, and then the child starts to develop a limp. And of course, as with a lot of other tumors, they may have constitutional symptoms such as fever, weight loss, and night sweats. Usually start off most orthopedic evaluations with the simplest imaging. So you normally start off with a conventional x-ray, and you may see areas of osteolysis with areas of osteosclerosis within the bone. So it may have this kind of moth-eaten appearance. But what tends to be a lot more distinguished is that you get calcifications which may be present in both the bone and in the soft tissue. And these calcifications can become so extensive that they look like just a burst of sunlight just emanating from the bone and the surrounding soft tissue. And that's kind of what it looks like there, right? You just have these calcifications just emanating outside the bone, looking like what they call a sunburst. You may also get other features, like what they call a Codman's triangle, which you can get it at the ends of long bones. This is kind of what it looks like. So you get a little bit of the periosteum lifting away from the bone, and then you get a base between the bone and the periosteum itself. So that's one there. That's a bit of a Codman's triangle there. And then you have this big burst of calcification that may be present in the bone as well. So these are some of the X-ray features that you may have in an osteosarcoma. So calcifications, you may actually see the outline of the soft tissue mass as well. If you were to follow here, you will see the outline of the soft tissue mass. You actually know that the mass is there, and it's actually a swelling compared to the remainder of the soft tissue which is around. So you may actually see that as well as one of the X-ray features. Now you want to further evaluate these patients by doing more precise investigations. An MRI scan is usually done, and this helps to assess the soft tissue a lot better. You're able to delineate the mass, you're able to see the size and dimensions, you're able to see what it's associated with, if it is in association with any important structures such as blood vessels or nerves. You're able to see the extent of it. You're also able to see the extent of the intramedullary component of the osteosarcoma as well, which sometimes is not very easily distinguishable on the x-rays. And you're also able to see if there are any what they call skip lesions, which are lesions which may be present a bit away from the main mass of tissue. And sometimes you may see these present, and the MRI scan, it's important to pick these up. And it's important to find these because if you don't treat for them specifically, they're a source of remaining tumor that's present. So it's important that you're able to image the entire length of the bone so you can see the full extent of whatever tumorous tissue is there. Lab tests may be useful. You get an increase in alkaline phosphatase, LDH. ESR may be high as well. Alphos, not so reliable because in children it's usually elevated anyway. But if it's massively increased, then it may give an idea that there is something that's producing a lot of bone within this person. So it can be useful for you to do these laboratory tests. So once you've done your X-rays and your MRIs, and you've defined your tumor, the next thing you want to do is to stage your tumor. And you usually do staging based on CT scan of the chest and abdomen, because osteosarcomas do metastasize to the lungs and the intra-abdominal organs. So that helps you to stage the patient and to see if they have any distal metastasis, and that will equal that they have a advanced or stage 4 disease. Once you've done that, then the next thing that you want to do is to confirm your diagnosis. And the only way you can confirm your diagnosis is to get histopathological appraisal. So you need to get a biopsy for you to confirm the diagnosis. So there's a lot of principles involved in getting this biopsy. First of all, there are different types of biopsies that you can get. You can start off by getting what they call a needle biopsy, right? And the needle biopsy can take the form of fine needle aspiration cytology or core needle biopsy. So it's indicated in specific situations. Needle biopsies you tend to do in patients where you have difficulty getting access to the tumor. So in obese patients or patients are in situations where the tumor is close to neurovascular structures, or it's in areas which are difficult to reach, such as deep into the pelvis or into the spine, then that's a situation in which a needle biopsy can become useful. And what should be added to this is that it's usually an image-guided needle biopsy. So you don't just stick blindly into the patient. You do some form of imaging, whether it is fluoroscopy, ultrasound guided, or CT scan guided, and that now guides their needle into the exact area of tissue that you want to biopsy. So I should add to that image-guided needle biopsies. Needle biopsies, the yield that you get from that is actually the cells of the tumor. So you're able to get cytology, but you're not able to get actual tumor architecture. And sometimes having tumor architecture can help you to distinguish between some tumors which are difficult to appraise. But most of the time, though, just getting the abnormal cells and looking at those will give you a clear indication as to what type of tumor you're dealing with. So you find that needle biopsies, even though it might seem simple, the yield is pretty good. You can get over 80% accuracy, 90% accuracy actually, with just a fine needle aspiration cytology. It's also good to use fine needle in doing things like checking for lymph nodes, and also if you have tumors which are like cystic, and you're not sure whether you're dealing with a tumor or infection, you're able to aspirate these cysts, and you can look at the tissue and look at the gross appearance, and then you're able to distinguish between maybe an infection versus what is actually tumorous tissue. So these are the situations in which a fine needle aspiration cytology is useful. Now, a core needle is what is probably more preferred. You get better accuracy, about 95%. You get architecture of the tumor. So you're able to see the stroma, you're able to see blood vessels, vascularization, those different things, and these help to increase the accuracy of your diagnosis. So you have things like true cut needle, in which it's a much larger bore needle. Usually it has to be done under some kind of anesthesia, whether it is local or something better, more potent than that. And if the tumor is accessible, then it is the biopsy, which is more preferable to a fine needle aspiration cytology. The gold standard, though, is an open biopsy. And when you're doing an open biopsy, now you're able to get as much cells, as much architecture, as much tissue as you would need to get an accurate diagnosis. So the diagnosis with an open biopsy is the highest. It approaches 100%. Not quite 100%, because you still get some which are indiagnosable, but it approaches 100%. It all has to do with how the biopsy is taken. So there are principles of open biopsy which we will get into in a little while. Now, an excision biopsy is usually reserved for masses which are small. So if they're less than 3 centimeters, and they're not likely to be malignant, meaning that they're not attached to any tissue, they're not deep into any deeply lying tissue. They're fairly mobile. They're not painful. Some of these features will give an idea that this tumor may be more likely to be benign. And it's usually those tumors that you usually go for with an excision biopsy. If the tumor is larger, so if it's 5 centimeters or greater, it's deeply embedded into tissue, it's attached to tissue, especially deep structures, then it's less likely to be a benign tumor. And you don't want to do excision biopsy for tumors which are likely to be malignant tumors. So let's go back to the principles of this open biopsy. So you don't do an open biopsy until you've done all of your clinical, radiological, lab tests. All your workup for the patient has been done before you do the biopsy. Usually, if the patient is going to be doing surgery for this tumor, usually it's the same institution that does the biopsy that you want to be doing the surgery as well. Reason being is that both need to be planned very carefully, and you don't want somebody else to be doing the biopsy and then you turn around and have to do the surgery, because then you'd have some difficulty in ascertaining how they went about approaching their biopsy and the different tracks and everything that they have used. So it's usually the same group of people who do the biopsy that you want to do the definitive surgical procedure. So you want to make longitudinal incisions. It's usually done under either general or regional anesthesia. You always have to bear in mind what the biopsy track is doing. Now, you have what they call compartments in your limbs. So, for example, in the thigh, you have anterior compartment, which is your quadriceps, posterior compartment, which is your hamstrings. You have medial compartment, which is your adductor muscles. And if the tumor is present in one compartment, what you don't want to do is make your biopsy tract which goes across compartments. So if the tumor is in the posterior compartment alone, your biopsy tract must be only in the posterior compartment. You don't want to start anterior to get into the posterior compartment to do a biopsy, because now you would have contaminated 2 compartments, right? And now, in order for you to cure that patient, you need to do a much more extensive procedure than if you had it restricted to just 1 compartment. So you stick to 1 compartment, longitudinal incisions, and you try to make as direct an approach to the tumor as possible. Bear in mind, not damaging any vital structures or trying to avoid any important structures, blood vessels, nerves, so forth. The biopsy tract must be in such a way that when you're doing your definitive surgery, you're able to excise the biopsy tract along with excision of the tumor itself. As I said, vertical incisions, you try to avoid tourniquets if you can. But if you have to use a tourniquet because you're suspecting a lot of blood loss, then you try not to exsanguinate the limb, because you don't want to be seeding tumor cells into the blood vessels before or after surgery. As I said, single incision, single compartment. Try to pay attention to the neurovascular, neuromuscular planes. When you get into the tumor itself, you try to avoid the most central part of the mass. Reason being is that as tumors grow, they tend to outstrip their blood supply and they start to necrose in the center. So if you biopsy from the center of the tumor, you're going to get a lot of just necrotic tissue and not representative tumor cells. So you try to stay more to the periphery of the tumor, and even better if you can stay where you have interface between tumor tissue and normal tissue. And this helps with the histologists or the pathologists in getting even more accurate diagnoses. You try to make try to take samples from multiple quadrants in the tumor, not just in one area. Gives you a better yield. And once you've done your biopsy, it's important that you get reticulous hemostasis. So you try to stop all bleeding by whatever means possible. The reason being is that more bleeding that you have, the more likely that you will contaminate the wound and the area with tumor cells and cause a further problem for the patient. You try to avoid using drains, even though you want to drain out whatever blood is remaining. Reason being is that having a drain coming out through the skin is almost like having a conduit for tumor cells to escape through the skin. But if you have to put a drain in, then you have to make it within the same track as the biopsy, so that that drain track can also be excised when you're doing definitive surgery. So that's just some of the principles of trying to get an open biopsy. And if you adhere to these principles, then you'll get closer to that 100% yield. So going back to our algorithm slide. So once you've done your biopsy to confirm your diagnosis, osteosarcomas, usually the first line of treatment is what they call neoadjuvant or preoperative chemotherapy. So you give a chemotherapy regime before you do your surgical management. And what this does is that if the tumor is sensitive to the agents that you're giving, it will shrink the tumor, downsize it, maybe downstage it, and it make your surgical resection easier, and your ability to do less surgery on this patient even better. Where was I? Right, neoadjuvant chemotherapy. It also gives you an idea of whether the chemotherapy agents are actually working. How it does this is because you have something to actually demonstrate that it's working, because the tumor actually shrinks in size. If the tumor size remains the same, or it still continues to grow, that indicates that the regime or the agents that you're using are not effective on the tumor. So you may have to switch to a different regime with different agents. Now, if you've already done the surgery and resected the mass that's there, then you give the chemotherapy. You have nothing there to kind of represent that the tumor is actually getting smaller, because you've already done surgery to resect the bulk of the tumor. So doing it preoperatively gives you, shrinks the tumor, downstages it, and also gives you an idea of whether or not the chemotherapy agents are working. Now, once you've done that, then you can repeat the staging of the patient, because as I said, it may be able to downstage them, and then you move on to your surgical treatment. Now, surgical treatment can take different forms as well. So let me see if I can find that. Let me probably go through this slide. I probably said most of this already. Chemotherapy, preoperative is neoadjuvant, postoperative is adjuvant. The advantage of neoadjuvant is that regression of the tumor, the primary tumor, right? So it makes whatever surgical procedure you're going to do easier. It may decrease the concomitant spread of tumor cells during or at the time of surgery. If you have micrometastasis that may be present, say for example, skip lesions, or it just is present in the area, it may actually help to decrease the load of these micrometastases. If there's any delay between surgical procedure and any other diagnosis, then giving the neoadjuvant chemotherapy helps to prevent the tumor from continuing to grow and progress during that period of time. And usually you give it about 3 to 4 weeks before you're giving your definitive procedure. Reason for that time lapse is that, as you can imagine, chemotherapy is toxic, and it does have effects on the patient and their tissues and their physiology. So it can decrease blood count, it can make them immunosuppressed, it can also make the tissue in the area of the tumor also subjected to difficulty with healing, and also to increased rate of infection. So you give that 3 to 4 week interval to allow the patient to restore their normal state of affairs. So restore their blood count, restore their immunogenicity, and restore the tissues to more healthy tissue to make it easier for surgical resection and healing of wounds post-surgical procedure. Now, in terms of the surgical procedure itself, now this is just to go through some of the principles of surgical resection. If you look at this picture here, you can see that this here is a tumor, and surgical resections can go, one, it can be intralesional, where you pretty much go straight through the tumor. Sometimes they call this a debulking procedure. And what happens here is that you remove as much of the tumor as you can, but you leave back a lot of gross tumor present in the tissues. Why would you do this? There are situations in which removing the entire tumor won't change the prognosis of the patient, but the tumor itself may be causing some kind of mass effect in the area. So you don't necessarily want to, be too radical in what you're resecting. You just want to remove the bulk of the tumor. It may be as well that sometimes these tumors are impacting on structures, which you want to remove this effect of the tumor on these structures. But the main thing is that either the tumor, it won't change the prognosis for the patient by doing an intralesional resection. You're just doing it just to debulk the amount of tumor mass that is present. Now, marginal resection is when you reset the tumor. You can see the M's there. So you sect it right at the edges of the tumor. So the tumor is gone in its almost completion, but you're right by the margin of the tumor, right by the edge. Now, what happens at the margin is that you get this, what they call zone of reaction or reactive zone. So you get a lot of inflammation, which can be, generated from the tumor itself. So you have inflamed tissue, and sometimes this tissue may have some micrometastasis present or some tumor cells present, which are separate from the bulk of the tumor. So it's a zone in which you may still have a few tumor cells lying around. So if you do a marginal resection, even though you remove the bulk of the tumor, you may still have tumor cells present, or at least reactive zone of tumor. And this may be subjected to the tumor recurring in the area because you haven't completely removed all tumor tissue. Now, a wide resection is generally what is preferable. And usually that means, you can see the W's here, you reset the tumor and you leave a margin of normal tissue. That way you get out of that zone of reaction, you get out of that inflammatory tissue area, you get out of that area where you have a few micrometastases or some random tumor cells lying around. So you have to take a zone of normal tissue with you in order for you to be sure that you've cleared the margin of the tumor. And this can vary from tumor to tumor. What's the recommended resection margin? Some tumors, it may be 1 centimeter, some it may be 3 centimeters. Back in the day, some bony tumors used to be up to 5 centimeters that you want a margin of normal tissue for you to, have a wide resection, and that would be histologically complete. Now, a radical resection, as you can see here, where the R's are, is when you remove not just the tumor, not just the margin, but you remove a lot of tissue with it. And sometimes you remove tissue which is not even associated with the involved tissue as well. An example of this is like if you have a breast cancer and you remove the lump, the axilla, and also you may have to remove the part of the chest wall, including the ribs and things like that. Now that's radical because you're taking tissue which wasn't involved in the actual tumor before. Sometimes this can be necessary if you have really aggressive tumors, or in the case of orthopedic tumors or bony or limb tumors, usually a radical resection usually means some kind of an amputation. An amputation can be that you do, say for example, if you resect here, that can be an above knee amputation. It's radical because you're taking the entire tibia or leg, which is not involved in tumor, but for you to actually get rid of the actual tumor itself, you have to actually amputate above the level of the tumor. Sometimes if the tumor is closer to the joint, you may actually even have to dislocate the joint, right? What they call a disarticulation of the hip or shoulder or whichever joint is involved. Or if the tumor even encroaches on the joint, you may have to take off the entire pelvis or half a pelvis, what they call a hemipelvectomy. So the extent of the resection for radical resection can go from one thing to another. Now, amputations were formerly what was most commonly done for patients who had osteosarcomas of the limbs, because it was thought that you would have the most complete resection, and you are now able to give the patient the best prognosis. And that's the key to what you want to do for this patient. You want to give them the best prognosis. So if you only do a marginal resection, your prognosis is not going to be as good as doing an amputation. That's your prognosis in terms of 5-year or 10-year survival. Because of neoadjuvant therapy, though, and we're able to shrink these tumors and downstage them, downsize them, get rid of all these areas of micromets, we're now able to get away with wide resections for these tumors in these limbs. Which also means that if you've now done that, you now have to be able to reconstruct the limb. And if you remove a big chunk of limb, how do you now reconstruct this limb with this big gap of tissue that's missing? Also bear in mind that these patients are all very young. They're preteens and teenagers. So for you to do an amputation at that age, to subject them to an amputation, it is radical, and if you can avoid it, then it's best done. Don't discount the use of an amputation, however, because whatever limb sparing or limb salvage procedure that you do for these patients, it comes at a cost, right? Either at a financial cost, at the cost of them doing multiple procedures, at the cost of them doing technically difficult procedures, at the cost of them doing procedures which can be wrought with complications. And if you do a good old amputation, the patient heals very quickly, and they can be fitted with a prosthesis and get back to normal life very quickly as well. And you've also ensured that they have their best prognosis in terms of their 5-year survival. And these are young patients who deal well with amputations a lot better than the elderly patients. Some patients, you put them with a prosthesis and they can continue on with their regular life quite readily without much problem. So amputation is not something to be tossed aside. It's just something that's an option. And especially in our circumstance, we are a poor country, and a lot of times we don't have the ability to do these limb sparing procedures, which we would want to do for these patients. So a lot of times we end up doing a lot of amputations for a lot of patients who present to us. So you didn't talk about surgery for these patients. The main goal is that you want to safely and completely remove the tumor. As I said, historically it used to be an amputation. Now we're moved on to limb sparing procedures. You give you neoadjuvant therapy, and then you go ahead. One adjunct or one importance for the salvage procedures is that it has to have the same prognosis as an amputation. That means it's 5 years and 10-year survival has to be the same of an amputation. If it's less, the amputation is still a better procedure than the limb sparing procedure. Now, what are some of these limb sparing procedures? If you look over here, say you have a tumor there present in the proximal tibia. Now you can actually resect the proximal tibia, right? And you can fit the patient with what they call a mega prosthesis or a tumor prosthesis. And this is what it looks like here. So it's like a knee replacement, but it's a lot more fancy and a lot more components involved in it. So you have this area which can go up and stabilize into the femur, this area that can stabilize down into the tibia, and then you have the knee joint, the artificial knee joint in between. So if you're able to reset the tumor, you're able to fit them with this tumor prosthesis. And the benefits of this is that it's immediately stable, so they can walk on it and use it right away. They don't have to wait for any tissue to heal. It gives them good functionality, and they can get back to a normal life very quickly. The problems with it is, as you can imagine, it's very expensive. This probably costs like around $8 to $10 million, this prosthesis. It's technically challenging to actually do the procedure. It's not something that any surgeon can do. You have to be specially trained to put these prostheses in. And of course, like with anything that's mechanical, it only lasts for a certain amount of time. And you're talking about patients who are very young, so they may wear these out, and that's one of the problems. You give them back their functionality and they overuse it, and then they can wear them out, and then they become loose and they start to give them trouble, and then you may have to do the procedure all over again. And each time you do this procedure, it becomes exponentially harder to try to do it. And of course, expenses on top of it as well. So that's some of the downfalls to doing this tumor prosthesis. One other things they can do is what they call a bulk allograft. So you have tumor here present in A. Now B is what they call a bulk allograft. So this is taken from a cadaver. So somebody who's very recently died within the last few minutes. In first world countries, you have people who are donors, who designate themselves as donors. And usually when they're dying or about to die, the donor team, the harvest team comes in and pretty much craps them from head to toe, takes all of their body parts, even their cornea, even their, different parts of them, their Achilles tendon, their patella tendon, they take all of these different body parts and then they freeze them and use them for other people, right? Usually you can either get it frozen or you can get what they call a fresh sample, where it's just recently, somebody who has just recently passed and it's not frozen yet. The fresh one is usually better because it tends to be quote unquote healthier, and tends to heal faster than the fresh one, but sometimes you have to get the fresh one. So this is actually taken from a cadaver or somebody recently passed. They have bone banks present in different parts of the world. We don't have one here in the Caribbean, but we get ours if we need it from a bone bank in Miami. So you take this distal femur, you resect out this portion of bone, and you put this part of the distal femur into this place where you resected the tumor from the bone. And of course, you have to stabilize it. So you use plates, different devices to stabilize it. So this is the allograft, which is now replaced into that area of resected femur. And you have this big old plate that's there attached to it. Now, drawbacks to this is that it too is expensive. I think it's about, not as expensive though, it's about $1 million or $2 million to get one of these things. Of course, you have to think about all the immunogenic problems, infection problems, transmission of diseases. All those things are things that you have to consider. They do their very best to prevent these things from happening, and the rates of those things happening is very, very minuscule, almost non-existent. Rejection of the tissue as well, but they tend not to be rejected, which is lucky. Very, very rare that does occur. But one of the main problems is that this procedure, you're depending on this plate for stability. And oftentimes these plates can break, the bone can become infected, and you may have to do multiple surgeries for these patients to facilitate or to address these complications. Also, this allograft, this bone has to now become incorporated into the patient's normal bone. As you can see here, it's healed, and this takes sometimes 2 years or more for it to occur. So while that is happening, it's all this pressure on these plates, and sometimes you break multiple plates before you get to the healing of the bone. So each of these processes have their pros and cons. Here's another interesting one for you. It's something called rotation plasty, right? Where you actually resect the area of tissue which is involved in tumor. You take the ankle or the leg, you reattach it to the thigh, and you turn the ankle backwards. This ankle is now going to act as a knee joint, right? And you get a special prosthesis. You put their foot down in there, and this ankle here is now acting as a knee joint. Now you may think, wow, this is probably very difficult for this patient to utilize, but a lot of people actually tolerate it very well, right? This is one such patient. This is a young girl who probably had some kind of a tumor or some affliction at her early age. She had that procedure done, rotation plasty. This is now her knee, and this is her in her prosthesis, and she's a dancer. All right. So these procedures can actually bring people back to pretty normal lives. But anyway, I think I've digressed a bit too far with that. Back to what we're saying. So you go back, so you try to see what kind of limb salvaging procedure that you can do. The tumor prosthesis is probably the most popular one that is done, or the most common one that is done now. I think the results are best using that one. So once you've done your reconstruction, then you do your post-op chemotherapy, and you base it on what your preoperative drugs were, the ones that you ascertain that they were responsive to, and you give them their post-op or their neoadjuvant therapy. That gives them a 5-year survival rate of about 70% once you've done apply these principles correctly. All right. I think I've had enough of osteosarcomas. They don't really respond well to radiotherapy. Chondrosarcoma, it's a malignant tumor as well. It arises from the cartilage producing cells. So unlike osteosarcoma, which arises from the osteoblast, this one arises from the cartilage producing stem cells or mesenchymal cells. Similar to the osteosarcoma, you have primary ones in which it arises in normal bone, in which we're not sure of the mechanism in which it occurs, or it can arise in abnormal bone with a secondary. So you can have things like osteochondromas, which you may have learned about in your benign bone tumor class, that can transform into a malignancy and become a secondary chondrosarcoma. Paget's disease again and radiation again can predispose you to getting a secondary chondrosarcoma. Older age group, so these are adults which tend to get chondrosarcomas, usually above age 30, rarely occurring in children. Clinical features are similar, except it tends to be a lot more insidious than the osteosarcoma. It's very slow, it's a very slow growing tumor. So the pain tends to be dull for a long, long period of time. You can feel it very deep inside the tissues. And they tend to have this for a long time, sometimes months to years before it becomes clinically a situation, before they find out about it clinically. They may also get a localized swelling to the ear, but once again, this is also slow growing. Or the bone may be diseased to the point where it becomes fractured. So they may get a pathological fracture. Or it may impair nerves or close to a joint. It's a chondrosarcoma, so it tends to occur close to the joint. So if it grows enough and impairs the joint, then it can have decrease in range of motion. It tends to be located in a variety of areas, not just in the distal ends or the ends of long bones, but it can also be present in the pelvis, in the ribs sometimes. So it tends to be in more abnormal locations. In terms of the imaging, on X-ray, you tend to have this scalloping kind of lytic lesion appearance. Scalloping because you see these little white swirls almost, and it expands the bone. And the cortex thins out, right? And it kind of almost what they call scallops, almost like you're scooping out the cortex of the bone. So you get these kind of scalloping lesions. You can get calcifications within them as well, but you don't get these kind of wide bursts of calcifications like you do in an osteosarcoma. Osteosarcomas tend not to expand and destroy the bone much, but chondrosarcomas do, and you can see it there. And once it expands and breaks through the cortex, this is probably a fracture to the cortex, then it can also grow outside into the soft tissue. And once again, in order for you to delineate this clearly, you do an MRI scan. So this is an MRI scan of the same tissue, and you can see where the tumor is very obvious on the MRI scan, and you can see where it is expanded outside of the bone and it's now into the soft tissue. This is actually probably some edema which is present with the tumor. And that's part of where you have that marginal or reactive zone if you were to do your marginal resection involved in this area here. Usually, your definitive management is surgical because chemo radiation tends not to work. Chemo radiation works best for fast growing tumors or tumors with fast cellular turnover. But in slow-growing tumors like these, it's much, much less effective. So you end up with definitive surgical resection, similar to what I discussed before, the osteosarcoma, as your mainstay of treatment. Multiple myeloma, as I said, is the most common malignant cell primary tumor of bone. It is a B cell lymphoproliferative disorder, and the plasma cells are what are predominantly involved. And that's why it is the most common, because the plasma cells originate in the bone marrow, and the multiple myeloma is a lot more common than osteosarcoma. So you have these colonies of plasma cells. Sometimes they can be solitary and present in one area or in one bone, or sometimes in the spine as well, but they call plasmacytomas. And sometimes these can actually cause things like spinal cord compression, and that's how they actually present with features like that. They tend to cause an increased amount of osteoclastic activity. And osteoclasts are the cells that break down bone. So when osteoclasts become very active, you tend to end up with a lot of lytic lesions present, and they tend to be widespread throughout the skeleton. If it's not a solitary tumor, multiple myeloma tends to be widespread throughout the skeletal tissue. So you end up with these multiple lytic lesions present throughout. The symptoms can be very difficult to detect, especially early on. Patients tend to be older, so these are more middle-aged patients, so usually 50s and 60s, sometimes 70s. They can present with weakness when they have a lot of lytic lesions in their bone. They can present with back pain if it involves the spine, especially if it's like a plasmacytoma. Or sometimes if the bone becomes so weak, the bone can fracture. And they can present with pain because of a pathological fracture. And usually the trauma that causes the fracture is usually very, very low energy. So a patient with multiple myeloma may just be rolling over in bed and crack, and they fracture their femur, which you don't get for anybody who has normal bone. So they may present like that. And because of all this osteoclastic activity, you have a lot of calcium that's being secreted into the circulation, and they can also present with hypercalcemia. There are then problems and symptoms that comes with it. So polyuria, polydipsia, moans, groans, kidney stones, and psychiatric overtones, as they always say. So kidney stones, calcium, hypercalcemia can cause mental status disruption or psychological disturbances, constipation, all these different things that they can present with. In terms of the clinical signs, if they have bone involvement in a specific area and that bone is become very weak, they may have bony tenderness related to that bone, or if the bone is already fractured, then they'll definitely have pain and tenderness related to that. As I said, if they have involvement of the spine, for example, that plasmacytoma becomes compressive to the spine, then you may have signs of spinal cord compression or nerve root compression, depending on what is involved. Now, if you do x-rays of these patients, first thing you see is that their bones is generally osteoporotic because of the high amount of osteoclastic activity. And once the osteoclasts absorb enough bone, then you start to see punched out. And they can be throughout this, and that's kind of what it is. So if you tend to do what they call a skeletal survey for these patients. So you do x-rays of their skull, entire spine, all their long bones, pelvis, and chest. And you will see these lytic lesions just scattered all of their different bones. This is a big one here. This one is they probably present pain from a lesion. And this one actually looks like it's either fractured or about to fracture. What else is there? Yeah, moving on. So how do you investigate them? They can be anemic. They tend to have high ESRs. They can have elevated white cell count. They can have renal function impairment, either because of the high proteins which are going through the kidney or because of the high calcium which is going through the kidney. Or they can present with hypercalcemia, which is something you always have to look out for because that is an emergency which has to be dealt with very urgently. Hypercalcemia can cause lots of problems, seizures, cardiac problems, different things like that. So they present with hypercalcemia, you have to address that very quickly. They have a lot of protein passing through the urine, and they have a lot of protein and in their blood as well. So you do a serum protein electrophoresis, and you look for what they call a M band or monoclonal band. You also do albumin, globulin, and total proteins, and you see what they call a reverse in the albumin globulin ratio, meaning that the albumin is usually higher than the globulin. If you see a globulin higher than albumin, that's a reversal. It usually indicates that there is some hypergammaglobulinemia, right? Which is what you can get from this monoclonal band. You can also get proteins in the urine, say the urine collections, what they call 24-hour urine collections, and you measure the amount of protein that's present in the urine as well. So these help lead towards a diagnosis, but the diagnosis is usually confirmed based on bone marrow biopsy, in which you plate or slide you get sample of the bone marrow, you put it on slides, and you're able to highlight or delineate these plasma cells or these myeloma cells, abnormal plasma cells. How do you treat it? Yeah, like with anything else, you want to control the pain, but hypercalcemia, definitely, you need to treat that, usually with lots of fluid intake and diuresis and different things, protecting the heart and protecting the kidneys. Other supportive measures, and of course you have the pathological fractures or impending pathological fractures, which you also want to treat as well. If you have solitary plasmacytomas, you may treat that with radiation, plus or minus surgery, depending what's necessary. But that's usually the situation in which you do radiation. If you want to go after a solitary lesion, that's when radiation tends to be indicated. Usually, chemotoxic agents, there are multiple different ones that can be used for multiple myeloma, and the regimes keep changing every few years with different drugs being available and being more commonly used. Steroids can be used if you have bone pain, but more commonly, bisphosphonates is also used if you have a lot of lytic lesions throughout your bone and lots of bone pain. So bisphosphonates is another important drug that is used to treat multiple myeloma. Before I get to that, of orthopedic notes, let me talk more about the pathological fractures. So these patients can present with pathological fractures, or they can present with what they call impending pathological fractures. You want to treat these pathological fractures, and your principle is that you want to stabilize the entire bone. So if you have say for example, if you have a fracture in this, it would make sense to just stabilize this area of femur alone, because you have these other throughout, and it will now become areas which can become fractured as. So you tend to use intramedullary devices which cover the entire extent of the bone as your treatment of choice. So intramedullary rods is usually a treatment of choice for long bones involved in multiple myeloma. All right. And for impending fractures, you also treat them with intramedullary rods as well. So you actually do the surgery and put the rods in before the patient actually develops the fracture. Reason being is that it's easier to treat pre-fracture than after it's fractured. And if you know it's about to fracture, don't wait until it fractures before you actually do the surgery to stabilize it. Okay, Ewing sarcomas, very rare in our population. It tends to be a lot more common in populations where you have more Caucasians. You've only ever diagnosed maybe once or twice in Jamaica, a proper diagnosis that is, not just a guess. Now they arise from the endothelial cells in the bone marrow. Similar to osteosarcoma, they tend to be about the same age group. They have similar features. They can be the ends of long bones, but they can also be in some of the smaller bones as well, like the fibula, the tibia, the clavicle. A lot of the features are similar to osteosarcoma in terms of pain. They can present with a limp. They can present with a soft tissue swelling or mass. And they can have the constitutional symptoms as well. X-ray features, not very, very distinguishable. They don't have the same sunburst type of appearance, but you do get a lot of calcification around the bone. You tend to see a lot of in bone involvement, meaning that you see the bone marrow tend to be involved a lot more than outside of the bone marrow when it comes to Ewing sarcoma. But the X-ray features aren't their best delineating feature. You do MRI scans as usual, and then of course you get your biopsy. And it's the biopsy that's going to really tell you that it's a Ewing sarcoma. And this is what I'm talking about. Cells with architecture. Architecture here is that you can actually see blood vessels. That's a blood vessel, that's a blood vessel, that's a blood vessel, that's a blood vessel. And you can see how these dark cells, they tend to congregate around the blood vessels. So you're not just seeing the cells by themselves, you're seeing how they are situated within their architecture, within their environment. So it helps to give you your diagnosis. And oftentimes Ewing sarcoma can be difficult to diagnose. But if you see these small round cells clustered around blood vessels, it's a strong sign as a Ewing sarcoma. Sometimes you have to send for special staining and what they call immunohistochemistry and things like that for you to confirm your diagnosis. But it's important that you get proper histological appraisal. The prognosis is a bit poorer than osteosarcoma. You tend to do it similarly in terms of the treatment. You do neoadjuvant chemotherapy, followed by a wide resection with limb sparing if you can, or amputation if it can't be avoided. You may use radiotherapy post-op in some situations, but post-operative chemotherapy is also used as well. The prognosis is poorer than osteosarcoma. Only 50% of patients tend to survive after 5 years, in spite of the best treatment that they can give them. So that's the end of primary tumors. Any questions? You guys still here? Hope I'm not speaking to myself.
Hi, Doc. Good morning.
Yes, sir.
Good afternoon.
You had, sorry, good afternoon. Sorry. You had said a chondrosarcoma may be secondary to an osteochondroma, but isn't an osteochondroma benign?
Yeah, so they get what they call malignant transformation.
Okay.
Comes in a small percentage of them, maybe around what, 2%, 3%.
And when might a marginal resection be indicated? Under what circumstances would you prefer to do a marginal resection?
Well, when you're talking about marginal, when I'm speaking about resection, it was a more general principle of resection. For osteosarcomas and sarcoma, marginal can be used in situations. So for example, you have a soft tissue. So you may have a soft tissue tumor, say in the forearm, and you have, say, your nerve, your median nerve, running just beside it, right? In that situation, you may not want to, if for you to get a wide resection, you'd have to actually remove the median nerve, right? Or cut the median nerve out, which should render the patient dysfunctional in terms of or less functional in terms of their upper limb. So what you may do is do a marginal resection, spare the median nerve, and then treat it with, say, for example, local radiotherapy. So you do it in situations where you have other treatment which can help to increase or enhance the treatment after you've done a marginal resection. So you made a marginal resection with local radiotherapy for soft tissue sarcomas. So that's an example of when you use it.
Okay, Doc. Thank you very much.
All right. Huh? Training program? What training program? You talking orthopedic training program? What is it like? That's a deep conversation, which is difficult to answer in this forum. That is a long conversation. So you'd have to address that at a separate time. How many years? Theoretically 6 years. Theoretically, most people tend to take longer to finish. All right. Yes. but don't worry, it finishes quicker than you think. All right, let us see if we can quickly do metastatic bone disease. This is actually pretty short. I actually have the wrong slides here. This was more for postgraduates, and I should have refined it for more of an undergraduate type of teaching. Well, let's just see what we can do with it. So metastatic bone disease. So we just spoke about primary bone disease. Now we're going to talk about metastatic bone disease. So as I said before, primary bone tumors occur in the younger age group, right? So when you start to get older, then if you see a bony lesion, then you start to think it's less likely to be a primary and more likely to be a metastatic bone lesion. And certainly if you see a patient over 60 or 70 with a bone lesion, it's almost always going to be a metastatic bone lesion. All right. So, okay. Oh. Yeah. I was just informed that I have a patient who is about to go to surgery, or who they're about to put under anesthesia for surgery. I thought I had more time. Okay. When can we complete this? What classes you guys have tomorrow? Or what timing? Hello? What's your schedule of classes for tomorrow? 8:30 and 2? 9:30. 8, 9:30 and 2. An exam at 5. All right, can I do this one at 11 o'clock? It's a short session. It shouldn't be very long. Yes, no, maybe so. All right, so we do this one at 11 o'clock tomorrow then. All right, sorry about that, guys. They just informed me that they're actually ready to start, so thought I had more time than this. All right, I have to run, so I'll continue you guys tomorrow.
Okay, Doc, remember to stop the recording.